My name's Sabrina Robinson. I'm a registered nurse. I've been a nurse for about a year. I work in a neonatal intensive care unit out here in Albuquerque, New Mexico. We're a level 2 NICU. And then prior to that, I actually worked out in Phelps. That's where I went to nursing school and did a lot of the VIP training, and I was an instructor with Franz, which is how we met. So we've done a lot of focus on communication in general and kind of understanding that from the negotiating perspective when we were trying to do it for de-escalation. And then a lot of that has transferred over into now when we work in the NICU and anything like that. So I'm just going to do a little bit on patient-centered care. So to start, just the definition of patient-centered care is providing care that is respectful of and responsive to individual patient preferences, needs, values, and ensuring that the patient values guide all clinical decisions. So essentially, in simple terms, the way I think about it is it's focusing on the patient as a whole person in their entirety of their life versus just focusing on the disease process or the medication or the treatment options that we have. Because everything that's going on in their life is just as crucial and important to their success as getting the right medications and things like that. Because in the simplest way, we can prescribe the correct medication, but if we don't set them up successfully to make sure that they're taking that medication when they're supposed to and following up and getting refills, then the medication isn't going to help them get better. So there's benefits to patient-centered care. So obviously a big, huge ones, especially for us, is increased satisfaction scores. So improved scores helps us in general in the medical field. The biggest thing with that, because it is a metric that's kind of iffy with it, is successful patient-centered care can only be determined solely by the patient. So even if we think that we've taken all the steps that we determined should be the best patient-centered care, if the patient isn't satisfied or doesn't feel that they understood everything, that they felt comfortable, that they had that kind of relationship with their provider or the staff that's helped them, then it's technically not successful patient-centered care. So unfortunately, that does mean that each interaction needs to be individualized to the patient because every single patient is not going to need the exact same things. So we can have an outline that kind of helps us guide it in the correct direction, but we can't use a cookie cutter outline for every single patient because we won't be able to reach them in the most optimal way. What this also helps us is an improved use of resources. So ensuring that we are using all of the resources that we can to help every single patient. And we do that actually by using the last one, which is increased communication among staff. So there's definitely resources that doctors may know about, that nurses don't know about, or that our care coordinators can know about, that the rest of the staff doesn't know about. So it's making sure that we can pinpoint a problem that needs some sort of solution and involving the entire care team to ensure that we find the best, most effective solution for the patient. And getting all of the resources and everybody's knowledge to help make sure that we can do that. And then in turn with that, it'll help us reduce expenses and costs. So if we can get a patient to effectively understand their treatment and why we're doing what we're doing and how to do it successfully, then hopefully we can reduce the amount of times they need to be rehospitalized or the amount of visits that they need to come in, or that we can get to the root of a problem that they're having because they feel like they can communicate openly and we will listen and work with them to determine what that is. So these are all huge benefits for making sure that we have a patient-centered care in every interaction. So for me, the goals that we're looking for is I want a patient to feel empowered. So I want a patient to feel like they can walk in to see their primary physician, or if they're on a hospital floor, and say, hey, this, and this is going on, and can we find a solution, and that they won't meet a barrier and they won't feel like they're a test or that they're a result or that they're being kind of pushed off just with medical jargon. So part of to do that, to make them feel empowered, is to guide their education. So understanding the ways that they learn, and we'll talk about that a little bit, and making sure that the education is the most beneficial and effective to them so that they are able to succeed. You also want to develop a trusting relationship. So it is crucial that we use listening skills and everything that we have in our tool belt to make sure that they feel like they can trust us. Initially, I mean, the biggest thing we were told in nursing school and everywhere else is, especially for nurses, we are a trusted profession. So they're going to trust us initially when they come in because they know that our goal is to take care of them. What we can't do is devalue that trust and in turn kind of make them have a fear from us or feel like they can't tell us everything or feel like what they do tell us deterred from their care. And then also that if we don't understand, we're checking back in to make sure that we are going at the root of the problem that they feel they have and not just the problem that we think that we need to solve for them. So a big key one in that is effective communication. So the communication and the listening, these are constantly growing skills that we have to have, and you can never truly master them, I've learned, even when you know all the things. So you're constantly growing them. Every single person needs a different interaction. So it's constantly being aware of how to be effective in your communication and your listening. And then, like I had said earlier, developing an individualized plan of care. So it definitively needs to be individualized to that patient, because the cookie cutter way is not going to give the most effective care, and then we're kind of detracting from the benefits that we had earlier. So how do we achieve this? Sorry, I talk fast. If anyone needs me to slow down or has a question, let me know. The biggest thing that we do, and everyone has covered, active listening. So the biggest thing with active listening is you need a genuine concern for the patient as an entirety. So it takes a little bit of time, but listening to everything that they have to say when you're able, or if you're not able, telling them that you'll come back and check in. So it's not always super time efficient to be listening about their family or about everything that's going on. But if they're comfortable enough to share that with you, sometimes there's little golden nuggets of information that you need, which is where you're listening for all the details about their life to determine what their needs are beyond just the medicine. So sometimes if you're sitting there listening, for an example, we've had in our NICU, we had a grandma that would talk to us about her daughter and the difficulties of her not coming to the NICU, and we were concerned why she was not coming to the NICU, and it ended up she was having kind of like a car problem, and there was a different things aligned. So it took time sitting there listening to the grandma talk about everything and talk about all of her kids and all of her life, and that kind of came up so that we were able to determine that that was a little nugget of information that needed to be solved. Whereas if we had just shut down at the point that, oh, well, the mom's not coming, we need to contact CYFD, which I think is DFS in Missouri, just because she's not coming. So it's very important sometimes to just sit down and listen to the stories they have to say, because then they feel more comfortable to be able to bring all the information to you, and then using your really keen active listening to kind of pick up on what might be a problem and what might be something that we could offer to help, and creating that into their care plan. Another huge thing is using your cultural knowledge. So specifically out here in New Mexico, we have a very, very high Hispanic population, and we have a very, very high Native American population. So there are a lot of traditions that go into when a baby is born, and it's being very knowledgeable and respectful of those in both of those communities, and how that affects them when they're in a NICU situation, specifically for me. So there are definitely things that nobody anticipates their baby going to the NICU, just like nobody anticipates going to the hospital. So being very aware of what those cultural things are to determine how we can make them the most comfortable possible, which is going to help develop that trusting relationship, that we are showing them equal respect about their culture and about them as a person as we expect them to give us, because we are medical professionals and they should be listening to us. So instead of demanding that respect straight out the gate, it's making sure that we're building that relationship by equally showing respect to them where we can. So the more you're able to actively listen, you can individualize that plan of care. So understanding that there are certain things, for an example, with myself as a person, knowing that, like, so for example, when I go in after giving birth to my baby in my postpartum appointment, we were talking about the birth control options. And when my OB was speaking with me about it, she was super good about finding out my lifestyle, how I do things. She definitely asked about the fact that I was a nurse, so I worked 12-hour shifts. She asked how good I was at remembering to take things at a certain time. And we talked about how in the past, that's why the pill hadn't worked for me, because I'm not super good at remembering things. And she knew from before, she brought up that I sometimes forgot to take my prenatal pills while I was pregnant, just because I would get caught up in life and I would forget to take them, and how important it was to not do that. So remembering a tidbit from when I was pregnant that I forgot to take my prenatals was crucial to her being able to determine what would be the best course of action for me. And that little remembrance kind of makes you feel special. So it was like, okay, so you genuinely did pay attention. You did know me. You do know that I work a busy schedule, that I work 12-hour shifts, that it's very easy to get caught up or forget things, A, when I'm at work, or B, in general, because I didn't do well before that. So those things are little tidbits that don't seem like they're important, but they matter later on. And that just, because I just had a baby, is just the tidbit that comes to mind right away, was that little bit of remembering. And it also makes a patient feel special. And that's important too, because now I absolutely love my OB and I recommend her to other people. And I trust her, if I was to have another baby and to go back in, I trust her to pay attention to what I'm saying and to listen to me. And a big part of that I will bring up that I did have in my labor was, in my labor, I was convinced that I had gone into labor, and I was trying to communicate that. But as a first-time mom, I genuinely don't know what labor feels like. And so I kept telling the nurse that, because I had to get induced and my contractions were getting really intense. And I kept saying that I felt like I had them before I was coming in. And she kept telling me that they didn't want to give me an epidural. They didn't want to give me any pain medication. That's the medication that I got doesn't normally cause women to actually have contractions or to go into labor. So I waited and waited and waited. And about 4 hours in, I called her and I told her I couldn't take the pain anymore. And she said, well, fine, we'll give you your epidural, which I originally didn't want. And I got an epidural. And when they went to check me, I was 4 centimeters dilated, and the nurse stops and she goes, oh, you were in active labor. And she apologized to me. And so part of it was, I felt justified that I was correct, that what I was feeling was different enough that I was in labor. But then also I wasn't upset at her, because she immediately apologized and rectified that misstep that she didn't. She just said that that's generally not what happens, and she apologized to me. So again, she was actively listening, communicating, and paying attention to everything. So she realized that what I was saying did mean that, and then rectified it, because originally she didn't. So those kinds of things are important, to be able to be listening and understanding, and then also apologizing when you make a mistake, because we make mistakes. Let's be real. So part of that is leading into the communication. So a big key one that I would harp on when I was a VIP instructor, anytime we taught a class, is utilizing understandable, appropriate terms. It is very easy to fall into speaking into what we're comfortable in, which can be shortening things. It can be just the medical jargon that we're comfortable in. And it is crucial to not do that. And I will always, every time, fall back to a moment when I was in nursing school. We were going into a room with a patient. He was a kind of middle-aged guy. He was heavy set. And we had to do education. So our whole point was, we had to go in there and we had to teach them about something, and something that they had. And we walked into the room, innocent, naive. It was at the beginning of our clinicals, and we were going to teach him about CHF. And we referred to it as CHF initially, told him we were going to do that. He was super sweet, was letting us do everything. And we started it out by saying what CHF was, that it was congestive heart failure. And the guy looked at us and he said, my heart's failing, and had no idea that that's what CHF stood for. He just knew it was a diagnosis that he'd gotten. And immediately, as new nursing students, had no idea what to do, had to immediately go run and get our instructor, but was the most epic moment to remember in my head, that this guy genuinely didn't know what CHF stood for, or it had been explained to him and he didn't understand it, and there was no reciprocation to make sure that he understood what was going on. And it was 2 very nervous nursing students that essentially told him his heart was failing, which is not entirely as what's happening, but that was his reaction. And so that's where it becomes super important to use understandable, appropriate terms. And I do keep that in mind always. That has always been a huge thing to me because it happened to me. But I do that in the NICU as well. It is very easy to do. We shorten neck. We call neck all the time. And it's parents don't understand what that is, and it can be a very scary thing, and it is a very scary thing, and they need, when we're teaching them feeding and things like that, it's important that we're explaining why but not terrifying them. So we make sure that we use those kinds of terms when we're using the terminology for the bubble CPAP that they use, or when they're intubated, those kinds of things. It's very important that we're explaining them in terms that they can understand. Especially in my setting, it is very easy to overwhelm a patient or a parent and terrify them about what's going on with their baby just because we're talking above their level. So a big thing that we've done to kind of help with that is, I know a lot of hospitals and adult floors do bedside rounding. We now do bedside rounding in the NICU as well. So we travel around, and the doctors actually get to sit there and talk, and the parents can ask questions, and we make sure that we do it on the actual intensive care unit side, we do it every day of the week and usually one day on the weekend. So we're making sure that there's always an opportunity for a parent to catch us. We make sure when they come in, they know that's when we do it. So we do it every day at 10. And then on the extended care nursery side, where the babies are less critical, but still more of our feeder growers, we do it 3 days a week. So they do it Monday, Wednesday, Friday. And again, we notify the parents that that's the time that we do it, and we do it about 11:30 when we finish rounds on the other side. So it's important to make sure that in those times, and I've done it before with our doctors and stuff, to kind of use terms that they understand as well. So another thing is understanding the patient perspective, and that has to do with their feelings, their emotions, what's going on. Being in a hospital is a scary, scary thing. And doubly scary when it involves your child. So this one has been something that I've really had to focus on, specifically in my specialty, that it can be terrifying, and understanding where they're coming from, that it's terrifying, understanding maybe their past. So if they've had a family member who's been hospitalized before and has passed away, we have parents that have had fetal losses. And so it is a completely different, terrifying experience to walk into a NICU when you've had a fetal loss than when you haven't. Still terrifying either way, but it is completely different. And so you have to understand the history of the patient and the perspective that they're having, or the parent, in my case, that they're having, in order to determine how we can communicate best with them. And then making sure that it's a shared understanding for anything that's going on. So if we know that this is the best course of action, making sure they understand why we're doing it that way, and what is the best way to keep it going. So a big one that we often have to do is we have a lot of NAS babies, which is neonatal abstinence syndrome. So they are our babies who are withdrawing actively on the floor. So explaining to a parent or a grandparent or whoever the person who is going to take custody of that baby is, why we're putting that baby on morphine, or on having to switch the morphine to a methadone or anything like that, takes a shared understanding of why we're doing that, what could possibly happen, and the whole process of how we score them, how we wean them, how we do all of that. And I can tell you, it's when we put a baby on morphine, we sit down with those parents and those people, and our doctors included, and our nurse practitioners, and it's like an hour and a half long conversation. It is time consuming, and there's charting that needs to be done. There's other things that need to be done, but it is super important in those instances, or when we have babies that have other things going on, to sit down and communicate with them to the point that they understand. Even if they ask the same question 15 times and you have to explain it 15 different ways, we have found that we have higher satisfaction when we have nurses and doctors that will sit down and do that, versus nurses and doctors who will kind of go in there, skim over it really quick, and just be like, if you have any questions, come back and ask me later. So part of it is definitely understanding all of that, communicating effectively, and then also Same thing that I've said in that understanding when you're not effectively the person that should be communicating. There are some times that I will sit in a room and I will explain something 15 different ways, and however I'm seeing it or I'm saying it is not making sense. There's no shame in trying to find someone else to explain it in a different way or to give you a different perspective, because you're clearly missing something that's not allowing either the patient or the family to understand it. And there's no shame in backing off and saying, hey, let me see if I can find someone else to help or some other way to get this to make sense to you. So there's that. Leading in all of that, being effectively communicating, it's education. Education is crucial to helping be effective in patient-centered care. And it's tricky because it's a really difficult thing. It's an easy thing to just skip over, and it's a difficult thing to like sit there and put the time in, especially when it's a shorter visit. So for inpatient, it's a lot easier. I mean, on the NICU, we have patients that are there for months. So we get to keep reinforcing positively this education and re-going over it with them. And every nurse is checking in to make sure that they can do this ideally, which is easier than when it's a short interaction, like in an ER or in a clinic setting. But the biggest thing is to make sure that you evaluate for learning barriers. So if there's something that can prevent them from learning, you also want to know their health literacy, any communication barriers. So we oftentimes, especially here in New Mexico, have Spanish-speaking parents and families that speak well enough to make it seem like they understand what we're saying, but their level of understanding when it comes to the medical terminology and everything is not there enough, and they do require a translator. So it's really making sure that there isn't a communication barrier and it's not something just to brush over. Equally so with learning barriers, we have had parents that have made it seem like they could understand and read what was happening, but then found out later that they actually couldn't read. So it's important to really get that done in the first place so that you're not having to go back and reteach things or have a patient be frustrated because we didn't do the initial evaluation of their education needs well. And then also some people know what helps them learn best, some people don't. So you can use all kinds of options when you're teaching. So we have printed materials. Again, it'll relate back to our NICU, and I think a lot of places have that. They'll have printed materials. We have books that we send home, both with labor and delivery, but we also have specific NICU ones that have everything about having a NICU baby. We do a lot of demonstrations. So we have occupational therapy and physical therapy up on the floor specifically to do with feedings. And they have like a doll that we use. We also, it is a requirement for us that they have CPR. So we have CPR dolls on the floor that we demonstrate with them. There's also a video that they watch. So we have a discharge video that every parent that discharges with a baby has to watch, that goes over the basics of care and the basics of everything they might need to know, and then has the information at the end. And it's also something they can access online at any point in time. And then obviously the shaking baby video. But then we also in the NICU require them to watch the video, CPR video. So they not only get the CPR video, but they'll also get a little bit of demonstration with us. And in the NICU specifically, we also have a doll that we use for demonstration for the shaking baby video. And part of that is because we have group classes, which is also an option. We have, until COVID happened, we had group discharge classes. So specifically to the NICU, they would go to a class out in our waiting room, and we would go over everything as a group. And then the nurse would touch base again prior to discharge individually with a parent. So it helps overcome the barrier of time constraints. So, I mean, it's difficult to sit down and go over everything with a patient. So that was kind of our way of overcoming a barrier specifically for the nurses needing to do a discharge. If they've already gotten the basis of the discharge class, then we can go back in and specifically go into the questions that are extra that they might have or concerns that they might have. And then teach back. We're huge with that in our NICU. It's the see one, do one, know one. So essentially the first time we teach a parent to feed, because that's the thing that we teach the most often, we will show them how to feed. So we do a lot of side lying feeding. We'll have therapy go in and we show them how we feed. And then the next time they'll do it and we'll stay there and observe them. And then they can do it from then on out for the most part. And we check in, obviously, but it's making sure that the first time we show it, the next time they actually do it. Same thing that we do with, we have like when they change the diapers on the preemies, micro preemies are a little bit different, but we want parents interactive with the babies. So we really want them touching the babies as much as possible and getting to do things with them as much as possible, especially on the intensive care unit side. So making sure that we're teaching them how to do those, having them demonstrate to us that they know how to do it, making sure that they're comfortable to ask us questions. And we have parents that are super comfortable with us to like call us in there to do stuff or go ahead and start cares without us. And it's building that relationship. And then they do know things. There are sometimes parents walk out there knowing more than the nurses know sometimes, like our new nurses, because they've just done it so many times and they've listened to the doctors and they've become so educated on their child, which is amazing to watch and shows that we are doing our education well. So when I was talking about, we have obstacles, obviously. So one of our obstacles was time constraints. That's a huge thing, is not having time to sit down to talk about and doing any of that. So finding ways to help and fix that. So our example was having a group discharge class. There's also staffing issues. So when we're short-staffed and you have higher patient to nurse ratios or patient to provider ratios, it makes it difficult to kind of spend that extra time, which is where that coming to check back in is, or utilizing care coordinators. I know the ERs have them, using those people to kind of help pick up the little gaps where there might be holes in what we were trying to do. There's also an inconsistency. Unfortunately, patient-centered care is, I don't want to say new, but it's definitely not every doctor's focus and not every nurse's focus. It depends where you're coming from, that's what you want to do. So sometimes it's frustrating because it's inconsistent from doctor to doctor or nurse to nurse, whether or not they're going to kind of focus on that patient-centered care. So making that more consistent is important. And in order to make that more consistent, there's often a lack of education. Obviously, Franz is amazing at doing education things, but in a lot of instances, there's a lack of education or a lack of time for the education. So making sure that we're educating on what patient-centered care is and how we can do it most effectively. And again, it's constantly evolving. So it's constantly changing what we need to do, and then it's individualized. And then a lack of leadership and follow-up and follow-through. So you really need not only your staff doing it, but you need a focus on it, a genuine focus on it from all of your leaders that are going to be leading in the hospital and all of your C team and those kinds of things, which you don't often see. There often tends to be like an umbrella version of it that they want done, but it's not a genuine one. So like we have an hourly rounding at our hospital, which we do fairly well, but there's definitely no follow through on it. And I've definitely heard from nurses and stuff ways that it could be done better and ways that it could be more effective. Especially when there's a higher patient to nurse ratio, and it's making sure that we can get the leadership to help us follow up on that. There's also a genuine misunderstanding of what patient-centered care means. So like I said in the beginning, when we were talking about the metrics, specifically when we're doing satisfaction surveys, the only person that can tell us that we've successfully done patient-centered care is the patient. So unfortunately, that makes it a little bit tricky, and it's a need to constantly be checking in with them to see how they're feeling, what's going on, anything like that, to make sure that it's not just the survey that we're depending on, it's throughout the entire visit. If not, it's very easy to start patient-centered or to have a moment of patient-centered care, and then it gets eclipsed by something else. And then again, a huge one for a lot of is too much focus on metrics. So there's the time constraints, there's like the focus on specifically the numbers from the surveys, or we have a huge focus on other things in the unit that are not as important as focusing solely on the patient. So like our charting and those kinds of things, which are important, but they do deter from specifically focusing just on the patient. So it's learning how to be really well or able to manage your time incredibly well, which is important to be able to make sure that you can spend as much time with the patients as needed. Especially if we have staffing shortages. And then those are the sources I use for my pictures. Does anybody have any questions or any concerns or anything that they wanted to say in regards to it for anything that I covered? No.
Oh, I just wanted to say, like, for the like third years that are on this call, this topic, actually what you're talking about, has come up so far in all my residency interviews, they ask about this. So it's important that you're able to speak about it.
Yeah, which is amazing, and I'm so glad that it's becoming more of a thing, and honestly was not something that I was super aware of until later on. So I'm glad that it's becoming more of a movement, and I hope that we can keep it going and that it can be more focused, because I think it'll make us successful. But I'm glad. I'm glad that they're asking, because I don't see that part of it. So I'm glad that it's something that they're also trying to focus on. Anything else? Okay. If there's at any point, I mean, I love doing any of this. I hope that this is something that you guys can take something away from. I know a lot of mine related specifically back to the NICU, because that's just where all of my experience has been. But I do think that the focus with the families and stuff is important. But I'm glad I could talk to you guys all. I'm glad some of you got to meet my baby. Thank you.
Thank you, Sabrina. Thank you very
Thanks.
much.
Thank you.
Thanks, Sabrina.